Today's topic on Keith RN, comprehending cardiac output. This is the first in a three-part series that will include understanding of cardiac output and the determinants of cardiac output that include preload, afterload, and contractility, and how this can and must be applied to the nurse's clinical practice. I will have a second video that will emphasize practical application of this to shock and hypovolemia and sepsis and orthostatic blood pressure changes. And the third video will address practical application to better comprehend and understand cardiac medications. Now, a nurse must have a deep understanding of the pathophysiology of cardiac output in order to have a deep understanding of cardiac medications, to correctly interpret orthostatic blood pressure findings and recognize early signs of any shock state, such as sepsis or hypovolemic shock. The following formula from anatomy and physiology that most and every student has had, usually as a prerequisite that is not contextualized to clinical practice, is this: CO equals SV times HR. And if you've had this content, you know that it is cardiac output of the heart equals stroke volume times heart rate. Now we're going to talk about this must not just be merely memorized to pass a test, but this formula is really one of the foundational need-to-know topics for every nurse and nursing student in order to really have the deep, critical thinking that will lead to a correct clinical judgment in clinical practice. So let's talk about this and how does preload, afterload, and contractility influence how much volume the heart kicks out every minute of every lifetime until that person ceases to exist. Well, let's quickly review each of these components of cardiac output. Let me just briefly share my background in this topic. I've been an RN for 31 years. I've actually been a practicing cardiac intensive care nurse for several years until I transitioned to emergency practice as well as general critical care practice, where I currently work in the critical care float pool of a large metropolitan hospital. I'm also a nurse educator for the last several years and have continued to work clinically and have never left the bedside and continue to practice in the critical care and ER settings. So that's my world that I swim in, and I see and I recognize the value of this principle in this pathophysiologic formula, not just to the critical care and ER settings, but it applies to everything that a nurse does in practice, regardless of where you end up. All right, so let's begin with the foundation of cardiac output. Now, cardiac output is simply defined by the stroke volume of each contraction of the ventricles, typically the left ventricle, times the heart rate equals the amount of how much volume the heart is kicking out every minute. It's obviously dependent on the heart rate and the volume in the ventricle. Now, 4 to 8 liters a minute is normal for the typical strengthy, healthy heart for the entire body. But whenever cardiac output is decreased due to dehydration, heart failure, hypovolemia, or any shock state, including sepsis, the first and earliest compensatory response by the heart is to increase the heart rate in order to maintain cardiac output. As stroke volume decreases, what's coming, we'll talk about preload in just a minute as it relates to what's coming in the venous circulation to the right atrium. That's going to influence, obviously, what's going to go into the pulmonary artery circuit, return to the left atrium, and then the left ventricle. So we see stroke volume decrease in any shock state. We're going to see the heart rate increase. So that is why the nurse must understand that with your patient, If your patient has an elevated heart rate without no obvious reason, this person is not having severe pain that would elevate the heart rate. This patient does not have a high fever that would increase metabolic, what the body requires, and seeing the heart rate elevate in that context, it's not that remarkable, but that heart rate is still over 90 or 100 at rest. That is always a clinical red flag that must be recognized, because that could be an early sign of a decompensation, and that patient may need to be rescued. So let's then talk about stroke volume. That's the other component of every aspect of cardiac output. Now, cardiac output, as we talked about with stroke volume, is simply the volume of blood that's in the ventricles that is pumped with each beat. And again, it's dependent upon what's coming to the right side of the heart as it relates to the superior vena cava and the inferior vena cava. In the venous circulation is coming into the right atrium, which then goes to the right ventricle. And if we have a low venous circulation due to venodilation or in any shock state, that stroke volume is going to be diminished. So let's talk about preload. Let's talk about what we call the determinants of cardiac output. Preload. Preload is simply the filling pressure of the right ventricle as well as the left ventricle. It is influenced essentially by how full is the body's tank and the amount of venous return. A higher venous return, so a patient in heart failure exacerbation has too much volume in the tank. That's going to result in a higher stroke volume, as well as increasing the workload of the heart, which is going to be responsible for that person's decompensation. A fluid volume deficit, whether due to severe dehydration, due to gastroenteritis, or any shock state, is going to result in a lower stroke volume. And there are medications that we'll talk about later in this series that do decrease stroke volume or decrease preload. One of those, for example, are the nitrates, the nitroglycerins that cause primarily venous dilation systemically, are going to impact and lower preload. Diuretics such as Lasix or hydrochlorothiazide that are commonly given to many cardiac patients, because they decrease the fluid volume within the body and increase urination and diuresis, are also going to decrease preload, which therefore then decreases the workload of the heart. So let's talk about the second determinant of cardiac output, afterload. Afterload is simply the force of resistance that the left ventricle must overcome in order to kick out its contents into the systemic circulation and open up the aortic valve, and then kick it into circulation arterially, going to the brain with the carotids and the jugular, as well as then the rest of the body with the descending aorta. Now, in essence, when you're taking your vital signs and you're doing the blood pressure, the systolic blood pressure is your exact correlation to the degree of afterload that your patient requires. So for example, when your systolic blood pressure is elevated, that increases the workload of the heart, of how hard that ventricle must contract and squeeze in order to kick out its contents. That higher systolic pressure is higher afterload. And that higher the afterload, the higher the workload of the heart is going to contribute to that patient's decompensation, unless the nurse recognizes the need to significantly decrease, and the physician or primary care provider orders appropriate medications to decrease that blood pressure. Usually can be Lasix intravenous, as well as even nitroglycerin to decrease and diminish preload. So as we look at that, that's essentially the essence of afterload. Afterload equals systolic blood pressure. That's very important for the nurse to remember. Let's talk about Starlings and Starling's law of the heart. Your heart muscle fibers are like a rubber band. They need to be stretched in order to have an adequate cardiac output. If our stroke volumes are low, for example, we're in a fluid volume deficit due to sepsis, going into septic shock. We're in vasodilation, and we're not getting enough volume coming back to the right side of the heart. Our stroke volumes will be less, and our contractility will be less. If we have an elevated preload, and we're going to have then that increased volume is going to stretch that cardiac muscle fiber this much, you're going to get a much stronger contractility. Now, as you know, in acute states, that can be no problem. But let's say a patient is in consistent volume overload, and that stretch is consistent for weeks and months. What's going to happen to this rubber binder over time? It's going to stay stretched, and it will have very little contractility, and therefore that's when you begin to see the cardiomyopathy and the enlarged heart that actually works against that patient and decreases the heart's ability to maintain adequate cardiac output. So I want you to know that when you look at the other aspect of contractility, your heart, in addition to Starlings and the Starlings phenomenon, think rubber band. So when you look at Starlings, just remember rubber band and think about that stretch that is required. But too little stretch, too little preload, not a strong cardiac output. Too much, yes, you will get initially a strong cardiac output. Sustain this stretch for too long, and it's going to damage the heart irreversibly, and that's the beginning of heart failure. Now, contractility is the final piece we'll talk about in today's video. And contractility as it relates to cardiac output is the inherent contractility of the heart, independent of Starlings. So this is the ability of the heart to contract adequately and the ventricles to squeeze, independent of how much volume, deficit or excess is present. It's influenced by calcium and the calcium action potential of the heart. So therefore, when you look at medications like calcium channel blockers, if we're blocking calcium, how will that affect contractility? It's going to decrease it. And that's why calcium channel blockers such as diltiazem are always negative inotropic medications that must be used in conjunction with heart failure patients. And we'll talk about that in the third and final video in this series. I want you to know that when I was teaching clinicals, my advanced students in the second year of the 2-year program I was teaching, they struggled with this content to practically apply these really kind of technical principles of cardiac output to clinical practice. And I created for my students several years ago a handout titled Comprehending Cardiac Medications, where I talk about in very simple language these determinants of cardiac output, as well as the main categories of medications and how they influence specific determinants of cardiac output depending on the mechanism of action of the cardiac drug. And I want to let you know that that handout's not available just to my students, but it's a free download that's available on my website, keithrn.com, that you can access through the link that's on this YouTube video. In closing, I want to share this. Nursing education is in need of radical transformation. One simple step that transformational nurse educators can do to strengthen student learning is to emphasize what is the need to know and most important content to clinical practice. In order to strengthen the critical thinking of students, they must be able to use and apply knowledge to the bedside. By emphasizing not just rote memorization of content, but application, such as the principles of cardiac output equals stroke volume times heart rate, you will strengthen the learning of your students and prepare them for clinical practice. Now, today's video was derived from my new book that I've just come out with this past fall, Think Like a Nurse, Practical Preparation for Professional Practice. Chapter 5 is dedicated to pharmacology and the importance of content that you need to know. Patricia Bender, the lead author of the Carnegie Foundation and one of my heroes as a nurse educator and researcher, was kind enough to review my manuscript and was also provided an endorsement. And she said this: This book would really be helpful to newly graduated nurses as well as senior nursing students. Keith gives a great example of situated coaching on electrolytes, cardiac preload, and afterload. I commend Keith on his scholarship and heart in this work. Whether you are a nurse educator or nursing student, my emphasis of highlighting the need-to-know content as well as practical application of the nurse thinking skill of clinical reasoning will not only strengthen student learning, but will help improve patient outcomes. If you'd like more about my book, go to my website, keithrn.com, and go to the store on the home page. I'd like you to check out the other videos on my YouTube channel, Think Like a Nurse, or better yet, subscribe and be the first in line to any of my new videos that will be coming out repeatedly throughout the year. Follow me on Twitter, on Keith Risher, or on Facebook at Think Like a Nurse. I hope to hear from you soon. Thank you.